All right. So hypertension, coronary arterial disease. I'm going to go over what I think is probably the most important stuff for the topic. Is there anyone that has any questions before we start going over the outline? Okay, it seems like we're good on that. Okay, so let's start with kind of talk about atherosclerosis as well as hyperlipidemia. Just kind of get general ideas, and I think focus in on your risk factors a lot. So, what would you guys say is the definition of atherosclerosis? Yeah, Shan says a plaque buildup in arteries that decrease blood flow. How does it build up? Is it fast? Is it slow? Over time. Yeah.
Over time.
Yep. So I'll write this down as buildup of plaque over a period of time. And then let's talk about the risk factors. So you kind of have to know what atherosclerosis is and some of the risk factors and the consequences. So what are some risk factors you guys can think of for atherosclerosis? Yeah, fatty diet, so kind of like obesity, poor diet, hyperlipidemia. So a lot of these risk factors are going to be relatively the same, but it's going to be important for you guys to kind of be able to name all of them, or at least be able to recognize um, all of them for a lot of these conditions because it ends up being pretty similar. What else can be a risk factor for atherosclerosis?
Hypertension.
Yeah, hypertension is a big one. And what's something that kind of a lot of these patients that have hypertension kind of also end up having hyperlipidemia. Yeah, smoking can be one. Lack of exercise, so like a sedentary lifestyle for sure. Alcoholism for sure as well. Those are usually when you're in doubt. Alcoholism, smoking, both of those can cause it. There's another one that's pretty common to see in a lot of patients that have um, heart issues or hyperlipidemia. So you'll see like hypertension, hyperlipidemia, and then like a third one that's super common, yeah, diabetes. So that's like whenever I'm coming up with like a mock scenario or something, it's always like I'll just throw in hypertension, hyperlipidemia, diabetes just in there. They usually go together a lot of the time. So these are kind of your risk factors, and you'll see these same risk factors for a lot of these conditions here. And I just want you guys to keep those in mind. Okay, so what are some consequences for atherosclerosis? What are the things that can be caused by having the condition? And again, you guys will find that a lot of these things kind of go together. Uh, CAD. So what other two things does that kind of go with? Yeah, MI, and there's like one more big one. PAD as well. Sure. Angina is kind of a part of CAD, so CAD is like angina, you're unstable angina. I guess I kind of just put angina, acute coronary syndrome, excuse me. Yeah, stroke as well. I remember one of your causes of ischemic stroke can be atherosclerosis because you have that plaque built up, and over time it's going to cause a blockage. So you can get those ischemic strokes. There's yeah, like the two types of ischemic strokes. There's the one that's caused kind of like by fatty buildup over time, and there's the embolism as well. But atherosclerosis is one of your things that can cause a stroke. And then PAD, that's your peripheral arterial disease, so or deficiency rather. So that's kind of the blood is kind of struggling to make its way down the rest of the body. You'll have um, things such as ulcers and lack of perfusion there, pain when walking because the blood's just not getting there. It's not oxygenating because of the lack of perfusion to your leg. And you guys will go over that a bit more detail later, but that's some of the stuff that it can cause. All right, and I want you guys to keep in mind all of these, because a lot of these family history can be a risk factor for sure. I'll kind of put it. Again, I think a big focus is kind of really worrying about those risk factors. Good education on it and stuff, understanding how the consequences go. And this can be kind of clustered similar to your upper GI or lower GI, where they share a lot of similarities. So just kind of think about a lot of these consequences are very similar. And real quick, I just kind of wanted to go over hyperlipidemia and then kind of like the parameters for it. What do you guys think about your total cholesterol? Straight from your guys' PowerPoint, less than 130 is optimal. A lot of the time, acceptable is under 200. Awesome. What about your HDL? So, um, greater than 60. So this is the one that's gonna drive. This is a lipoprotein that's gonna help put some of that cholesterol back from our blood over to get it out of our blood back into like the liver or other places that we store cholesterol in. So yeah, above 60 is good. We want this one. So the H, I think of H for happy. We're happy when this is high. And then LDL, how much do we want this to be? Yeah, right of your book. So I think of L like this is the one we want to have low. So we're happy when HDL is high. We want LDL to be low. Perfect. And just some general dietary guidelines that you guys can think about. So a lot of teaching can be important here. Like fruits and veggies, fiber can be good as well. So let's see. Think of fruit. Limit your yeah, let's saturated fat. Sure. Some people are affected, so something you guys don't really have to know too hard is just that sometimes for a lot of people the dietary cholesterol doesn't actually affect their blood cholesterol. It's more about the saturated fat, but for some people, having a high cholesterol diet um, can affect their blood cholesterol. But a lot of the time, it's really your saturated fats. And there's a lot of foods that are high in cholesterol that are actually good for keeping your blood cholesterol good, like avocados or almonds. They can be high in the cholesterols, but they're also high in unsaturated fats, which are actually good for you. Eggs as well. Eggs are high in cholesterol, but they're also high in all of these oily, unsaturated fats, polyunsaturated fats. So they're actually good for you long term for your cholesterol levels in your blood because your body actually adjusts. Your body actually makes its own cholesterol. It will adjust based on your diet for most people. So some people, you might want low cholesterol diet just because their body isn't as efficient. We said as well high fiber diet. I think that kind of goes with the whole vegetables. So kind of go with that. Limit sugar. I think that's also, yeah, fair. Limit sugar, sweets in general. What else do you want to limit, do you think? Again, it kind of goes with trans fats. Yeah, in general, we want to limit trans fats. And that's kind of just like a general health guideline. So trans fats, legally, we need the minimum, like legally, products can't really contain too many trans fats. I think it's like actually illegal. It's like it's not legal to have products that have too many trans fats because they're actually some of the most harmful um, fats for the body. Caffeine, I'm not sure if there's a specific one for that one, but alcohol for sure. And then I'll also throw in like exercise. That's actually not really dietary guidelines, but yeah, weight management in general. And like manage weight. And it's like dietary. Everything else is good there. Okay. And then maybe just like a quick on your medications that you guys go over. Try to just keep it simple on this. So what are some meds you can take for your hyperlipidemia statin medication? Yep. Yeah, statins, niacin. Yeah, you can take omega-3, fibrin acid derivatives. So that's usually just your fibrosol. And someone said ezetimibe um, before. Yeah. Ezetimibe. The bile acid sequestrant. So that would be the, let's see. Yeah, so bile acid sequestrant. If anyone speaks Spanish, sequestran is like sequestrar, which is like to abduct. So they're like abducting some of the fatty stuff in the bile acid. All right, so let's kind of talk about just like a quick thing with a lot of these medications. Um, rhabdomyolysis is very something to really keep in mind as well as like hepatotoxicity. So statins, I just want to kind of go quickly on this and focus more on some of the other stuff. Not spending all our time just kind of talking about the medications. This is like hepatotoxic. Hepato Well, think about your liver function. So your statins directly affect your liver because your livers are one of your prime creator producers of your cholesterol. So you don't want to check LFTs and stuff, bilirubin, signs and symptoms of jaundice, and then you're also going to be monitoring your rhabdo, which is so what when I say lab rhabdomyolysis, what do you guys think about? What are some things you want to assess or you want to tell your patient about when it
Report any muscle pain.
Yeah, so you want to educate patient on reporting muscle pain. So rhabdomyolysis is going to be the breakdown of muscle. So when we have this breakdown of muscle, it's going to cause that muscle pain. What's the complication that can happen with the rhabdomyolysis?
Can your heart stop?
Kind of, yeah. I mean, what does that kind of go with?
A heart attack?
Sure, that can happen. It can happen because of a very specific, as someone already mentioned it, but yeah, Alexis mentioned hyperkalemia. So the reason for that is this is a breakdown of your muscle cells. Remember that your cells have potassium in it, so when they burst, they release a lot of potassium, and so it can cause uh, a shift of potassium. So you can get hyperkalemia, and then that can affect your heart. Kind of where that connection goes in. So kind of whenever you want to think about the cell lysing, that's something that can happen. So when people get their blood draws, sometimes you can get the blood draw can hemolyze, meaning like the however it was taken or extracted out for a sample, it caused some of those red blood cells to pop. So you'll get a false positive on your potassium levels. Something to keep in mind. Okay, so when it comes to setia or ezetimibe, the only thing again, just to monitor LFTs because it's hepatotoxic. Trying to see if this one is gonna be causing the rhabdomyolysis. This one maybe like an angioedema, so that's your uh kind of like the inflammation of the tongue. Not to be confused with glossitis, which was with your vitamin B12. But that's a medical emergency because it can cause airway obstruction. You have your tongue, it's inflamed, it can cause you airway obstruction. So think about your niacin. This is also called vitamin B3. Again, we're just gonna turbo through these. It's not, you're not a pharmacist. So let's see. I think the main thing with this one that I have for it is usually there's not too many symptoms. So usually just take with food effects. And what are some of these side effects? It can just be your nausea, diarrhea. Your omega threes. How do we want to get our omega threes? If someone asks, what's like the best, if possible, how would you want to get your omega three? If possible, we want to get it through diet rather than just supplements. So it's going to be more, it's going to be preferred to get it through actual food. Feels okay. Prefer to, nothing wrong with taking the supplements, but if possible, we'd rather them actually have the food directly. Then gem fibrinosyl. Main thing I think about this one, I think this one can cause some stones, some gallstones. You can take it with food. So some of these have similar things. So take with food on some of these. Food, take with foods to decrease GI symptoms. Um, ooh, can cause some side effects like nausea, diarrhea, and the ones I see in a lot of like questions, gallstones, and the way I remember it is the word on gem fibrosol, the word gem, kind of like a rock. So I think of gallstones going with gem. Kind of how I remember this med can cause. Okay, let's see if you guys have any of the bialysosequestrin. The only example I have on lamb. Let's see. So kind of like the way it works is this medication will essentially bind to the some of the cholesterol or kind of excretion through feces. Let me double check my on that one. Does that sound right to people? You guys really up to date on? And then any questions on anything we talked about? These, I'll be more specific by preventing their reabsorption. Want to be somewhat specific on this in case you guys get asked another one of those questions on and where it's like kind of just med work. I think you guys had. I heard some of you guys talk to me about the mucolytic one. You guys can take everything. All right, so no questions. So I think we're making pretty good progress. Let me know if I'm going too fast. I am trying to make sure that we don't have another situation where we're running out of time. Okie dokie. So let's talk about hypertension. So one that you will see so much all the time. What's the difference between an essential and secondary hypertension? Yeah, so yeah, there's no really specific cause of essential hypertension. It's kind of got like that unknown etiology. If you guys were, yeah. So if you guys have um seen maybe like a Kaplan question, there's like a Kaplan question. So it's kind of um, like an unknown etiology. So we don't really know exactly what can cause it, like, or we don't really know like very specifically causes it, but there are some risk factors associated with it. Can you guys think of them? So some of these things that can increase the chances of you having essential, but there's nothing specific that yes. So I mentioned family history, hyperlipidemia, of course. So is there obesity, alcohol, your race? So specifically, um, what do you guys think on? Yeah, so African descent, African American, tend to have higher risk of hypertension and a lot of cardiac condition. Well, I think that we mentioned, yeah, smoking. Usually for me, when in doubt, I think smoking on a lot because there's how many toxins in like a cigarette. But yeah, you see like how a lot of these are actually very similar to your atherosclerosis. So a lot of these kind of overlap. So it's good to just kind of keep them in mind, kind of try to cluster them together instead of thinking, okay, my atherosclerosis is this, and then my hypertension is this. Think about which ones are similar on both, and just kind of remember it. These are perfusion based risk factors, and I would probably say stress. And then your secondary. So what are some conditions that can lead to secondary hypertension? Pregnancy is one. So we have that gestational. Oh, well, we have like the hypertension with the pregnancy. There's the eclampsia. Essentially, you guys will learn more about that. Kidney disease. Yeah. So remember, your kidneys and your perfusion in general really go together. So sometimes you can have that kidney disease. It's actually the most common cause of secondary hypertension. Yeah, diabetes is another one. So it's another one that can cause your thing. Yes. So this is a big one here, especially as you guys go into obese. So your estrogen, your oral contraceptives. In general, oral contraceptives are going to increase your risk of clotting and also hypertension. So the reason for this, just if you guys want to understand the cause for it, is uh, think about when someone is like a woman's going to give birth, and body knows it's going to be bleeding once it happens. So the mother will give birth, and then the placenta will come out, and there's going to be some blood. Your body's basically preparing itself for essentially having like a planned hemorrhage. So having the buildup of estrogen, because your contraceptive a lot of time is estrogen, your body essentially gets put into what they call like a hyper clotting state, because the body is being tricked into thinking it's pregnant almost. So your body is like, oh, if I'm going to be pregnant, I'm going to have to prepare myself for bleeding. So oral contraceptives will increase the clotting and also increase the risk of hypertension. Okay, something to keep in mind for the future. Yeah, and someone's like Cushing's. That's, guys will learn more about this. Cushing's disease associated with corticosteroids. Cool. Any questions so far on hypertension? Sure, you guys see it a lot. And then here I kind of wrote a relationship with kidneys and other organs. So when you do have your hypertension, remember you want to think when thinking of perfusion, always want to think about. So I made the analogy before. I could even change the analogy a little bit. You could say your kidneys is like a baby, and your heart is like the mom. When your kidneys are, or so when mom is struggling, there's too much stuff going on. The kidneys don't get enough attention. And the little baby is starts to cry and throw a tantrum, and then the mom becomes overloaded with all this stuff going on. So a lot of the time that can lead to swelling overload. I don't know if that helps you. Kidneys struggle, so it releases RAS, and that leads to overload because the mom, aka the heart, is being overloaded with all this stuff going on at once. When the heart is struggling, and the perfusion is struggling, your kidneys are struggling. Does that analogy help at all? Does that help anyone? Did I make it more confusing? No one's saying anything, so I'm going to assume I made things. Yeah, your kidneys are super sensitive, so it's like kidneys is a big baby. So some things you guys can think about when you have um, poor perfusion can be fluid volume overload. Your body does RAS, it retains things. That's where a lot of your heart failure comes in. Your hypertension can cause your heart failure. That's kind of where that goes into play. Your urine output can be taking a hit. So think about your shock. When you have shock, eventually you start compensating. Your RAS system is one of your compensations. So in that case, because you're like a hypovolemic shock, you're lacking in fluids, so you might not have overload. Instead, your body will be shutting, and that's where your body doesn't want to get rid of fluid, so you'll have that fluid retention to some degree and a lot of urinary retention. Now, as you guys will learn more, your hypertension can also cause uh, you to have um, issues kind of with your liver. You have like pressure in your hepatic system. Uh, that's for later. But just kind of think about how there's a reason why your circulation, your perfusion is one of your ABCs that has such a big impact on your whole body, especially your kidney. Kidneys really, and your kidney is one of your most important organs. When you want to think about a lot of medications, they affect the kidneys. Pretty much everything has to go through the liver and the kidneys. That's why all your meds are going to usually affect one or the other. and they have side effects. Oh, this is where you can monitor some kidney labs. EUI and your creatinine, you will learn a lot more about this so far. Urine output. So what are some physical symptoms of your hypertension? Does it apply to everyone? So yeah, headache can be. Yeah, it is usually asymptomatic, so it doesn't apply to everyone. So can't be asymptomatic. It's called like the silent killer. People don't know until they start having issues. But some people can have headaches and yeah, blurry vision for sure, dizziness. Yeah, when you have a hypertensive crisis, that's where a lot of these symptoms then start to really come into play. Pain is a big one. Anyone said that yet? Yeah, blurred vision. uh, Hypertensive crisis. Yeah, yeah, that's true. Bloody nose. I think that can happen, but fainting, stress. Can the hypertension cause? I'm sure it can. But I would say these are probably like the main ones to think about when you have that hypertensive crisis, or also some people will be affected physically by the hypertension, though a lot of times it is asymptomatic. So that's something to teach the patient because they might be like, oh, why do I need this? I feel fine. You have to explain kind of how it doesn't really have symptoms and the consequences that it can have. So what are some labs that might be associated with your hyper? Kind of actually already talked. I just want to come from your guys's keyboards, I guess. That's it. Yeah, I just kind of wanted to again reiterate how much the kidney apps um yeah, so like insulin, your fat. So usually, yeah, the cholesterol and stuff, that's what's gonna usually cause the hypertension sometimes. Like obviously it's can't directly point it to anything, but if all your kidneys you can do a cholesterol urine UA as in urinalysis or hypertension. What's the rationale behind that? I guess if you mean like a creatinine clearance, maybe is that what you guys are going with? Or like protein in the urine? I could see that, sure. We could do that. So your analysis to look for hematuria, I'm guessing, proteins, creatinine clearance. That can make sense. You guys know what urine would look like when it's got protein in it? Filtration rates, the GFR. There's like a very specific urine with protein. Foamy. Very foamy. Yep, yep, yep. So let's talk about the consequences of hypertension. You'll see these will be very familiar. A lot of the things that can happen. So there's like a nice slide that I really like in the PowerPoint. That kind of has it, kind of it's like a circle, it says hypertension, and it has a few other circles of stuff that kind of go along with it. Angina can be one of it, sure. AD, nothing going. Renal failure, yeah. Renal failure, PBD, so the peripheral vascular disease, which you guys will go over maybe like for you guys. I don't- Yeah, so that's where the stroke. So again, you guys can see a lot of this is very much similar, pretty similar. So what is some education we can do for these people? Yeah, so low sodium diet. So remember that's the cardiac diet. Really like less than 2 grams of salt, usually pretty typical. I get some, yeah, wait, mm, increase exercise. Does mention limit caffeine and alcohol. Patients great. Again, kind of that same diet. uh, Saturated fat, maybe cholesterol, depending on the person. Yeah, stress can be something that, okay, awesome. So now we'll go over the medications. I just want to see how good I'm on. I think I'm actually doing pretty medication. So this is going to be your heart failure medications a lot of the time ends up going along with it, get the dash, basically. So list me all the medications you guys can think about for your hypertension. Okay. Blockers. Oh, someone's got a mnemonic here. Dogs bark at cats always. The blockers, AK, yeah, ARB as well. What else can you guys think about? That might be good. Good. Blockers. That's a lot of your the alpha blockers, I believe, are tip. All the alpha blockers are usually for like the BPH that I see. Adrenergic blocker is not specific enough because that's just adrenergic is just, I guess that's kind of like your because it's like beta adrenergic blocker. to be specific. Anything else you guys can get for? So the Droxin is one of your heart failure meds. It's going to increase heart possibility and stuff. For pure hypertension, I don't think it's too commonly given for that, but it is one that is used for hyper. We'll put it somewhere. Maybe if we have room somewhere. But I do want to talk about the Droxin. There's another one. Think about your Mona. What's another one that's not listed for that for blood pressure? Yeah. What's a nitro is what class? What can you think of for the V? Yeah, it's a vasodilator. So I'll give you guys some examples here. So we have lisinopril, losartan. It's for an arm. What are the key things to keep in mind with your ACE inhibitor or and your ARBs? What are how do you know that it's safe to give? What are the things you're looking at? Know that it's safe to give. Monitor. No, sleeper. Angioedema. Lisinopril can cause coughs. When you have a cough and the patient is taking lisinopril, first thing though, you assess their lungs because is it a cough because of the lisinopril or is it a cough because you're going into heart failure? So that so that's something to assess for. Um, uh, uh, First of all, so assess by assessing. Does that make sense on that? Yeah. So you guys actually didn't talk about actually one. Yeah, you guys. Um, yeah. So you're gonna monitor your potassium. So when you're actually choosing if the medication is safe, you're going to be assessing for the potassium and also your blood pressure. Does not affect heart rate, but only affects your blood pressure. So, like, when would you hold it with your BP? Depends on some literature, but as long as you guys have the general idea, it should be good. Either, yeah, I've seen under 90, I've seen under 100, so it really depends. It depends on your hospital, actually. I think in literature, I've seen a lot of under 90, but it depends on your hospital. A lot of under 100. It really depends. And also it depends on the patient's baseline. If the patient's baseline, well, I guess if the patient's baseline would be that low, then they probably don't have hypertension, but you guys get what I'm saying. But just keep in mind your ACE inhibitors are not do not affect your heart. So your key things here is going to be your blood pressure and your potassium. And then once you actually give it, you're looking out for your angioedema. And it can cause a nagging cough, but first things first is rule out heart failure by assessing lungs. Maybe it's not that it's the lisinopril causing the coughs. Maybe it's pulmonary congestion, pulmonary edema, one of those things. So assessing blood pressure, monitor your potassium. That's your key things with your ACE inhibitors in arm. But or I think that's like you'll see. Some diuretic. Cool. It's a cool mnemonic. So A for angioedema, C for the cough, E for electrolyte imbalance. Pretty cool. These are awesome. So some beta blockers. I'm gonna give you guys examples. Um, no. What's some other ones? Propranolol. Can anyone think of another beta blocker? Betalol. That's actually the betalol. Tylenol. Yeah, it's already here actually. So these are some examples of your beta blockers. So what does this affect? What would you check before giving a beta blocker to make sure it's safe? And it's mentioned way, BP, and heart rate. So this one affects both your blood pressure and your heart rate. When you hold it.
Under 60?
Yeah. Well, your heart rate, yeah, or 50, depends on whatever you're reading. And there's 50 or 60, it depends on sure. And yeah, I've learned that it's under 90 and personally, and I learned the heart rate also under 60 personally, but whatever they're teaching you now is what I would go with. Yeah, it depends on what they're teaching or what info. It depends on your hospital policy, whatever. But I learned that as under 90 for blood pressure and under 60 for blood pressure under 90 systolic. So I guess I'll specify systolic. Okay. And then some extra stuff to keep in mind is there is cardio-selective and non-cardio-selective. So some beta blockers can affect your lungs. So people with COPD or asthma should not be taking specific beta blockers. So the way I remember it is metoprolol and atenolol are cardio. So I think of cardio selective. So someone I love, I met them and then I took them out to dinner. So met and then we ate dinner. How I kind of think of it. And then and then the other ones, pretty much the other ones are not cardio selective, so they'll affect the lungs. They're probably the two most common cardio selective. Okay. So that's so hopefully that was helpful. I don't know, you guys want me to write it down? The thing I said. Cardio selective, only the heart. So with my loved one, I met them and then we ate dinner on a date. They do. Yeah, they can cause like bronchospasm. So yeah. So 1 MA, 1 heart equals B1. Yeah. So in terms of like remembering your only have one. Oh, I see what you're saying. Beta blockers cause palpitation. Pain, I mean, mm, it's lowering your blood pressure. Maybe if it gets too low, usually I think of palpitations happen from something that would be agonizing the beta. So beta blockers don't actually affect your potassium, or at least they don't. It's not like we don't assess the potassium. for beta blocker. Only really for ACE inhibitors, of the other ones. I believe, yeah, beta blockers should use the. Okay, so some channel blockers. Lodipine is a common one. Um, Cardizem, Thiazem is the generic down. Thiazem, Verapamil. These are the most common ones I can think. Okay, so with this one, do you look at blood pressure and heart rate, or just heart rate, or just blood pressure? Yeah, so there are different, so all your peens, and some of your, how do you say? Again, this is some extra info from farm, but some of these actually are actually going to affect the blood pressure more than the heart rate, and some are going to affect both. I don't think you need to know that far. I would assess, in general, I'd probably assess both for these. So same mechanics as the other ones for you to think about. Nothing else to really go over. This can also treat angina and stuff. And these to treat, it's definitely not your first line. Your first line is really going to be your lisinoprils, your ACE inhibitors, your beta blockers, your diuretics usually, but CBP is usually not used as a first line. Usually as a additional med, and you'll probably learn a little bit more in 232. They can also help uh, patients with a lot of protein leakage, decrease protein leakage, or kidney people. Any questions so far? So the one you can't take with Viagra, the one that you'll hear people asking for that is part of your MONA. I think that's the nitroglycerin. They'll ask you, do you take Viagra when they're coming in with chest pain a lot of the time. But I wouldn't be surprised if there's a lot of them that you don't want to take with Viagra. So let's talk about diuretics. So there's two classes of these. So let's call them the potassium wasting and the potassium sparing. What can you tell me about these? So let's see what you guys said. Increase. I had no diuretic or potassium. They're pot wasting my pot. We don't like it when they waste our pot. Um, So yeah, so what are some examples of them? So that's loop diuretics.
The kidneys too.
Yeah.
What way do they affect the kidneys? By the way, I did not hear.
Keep drawing the room just now. We were both doing the flu shot clinic today. So that's why we weren't at skills lab. Some of you guys got our yeah, yeah, I saw Caleb, I saw Lori, I saw Anne, what else did I see? Twalde, Aha, saw a good amount of you guys. Yeah, sorry. So let's see, where did I go here? So loop diuretic, what's your probably like your number one example of this? You don't want to give potassium. Yeah, so potassium sparing meds like spironolactone. Oh, uh, I was gonna ask you. but I
Bro.
said it. Whatever. Yeah, because the ACE inhibitor is gonna increase your potassium. So if you're getting a potassium sparing one, that's gonna lead to hyperkalemia.
I was gonna say typically if they're taking a medication at home, that's like sometimes they have combination pills, the combination diuretics and ACE inhibitors. For example, you might do something like HCTZ and lisinopril together in a pill. Because one of them's potassium wasting, the other one's potassium sparing, so they kind of try to even it out. But I saw affects kidney function.
Mm-hmm.
So what do you expect to see with that? Like what labs or what amount? Increased BUN and creatinine.
Yeah, so I always want to hammer down how much perfusion affects the kidneys. Yeah, nobody gave me an example of a loop diuretic yet. Yeah, there you go. Ooh, Mary was on top. That immediately.
Lupin that thiazide can cause gout. I forgot that's the thing.
Yeah. That's like your most common most common one you'll see. Then there's like another one I see with like semi or amine. You have
It's all your
thiazides.
semites.
These are all end in thiazides. Hydrochlorothiazide, on HCTZ, and your potassium sparing your spironolactone. So obviously you're gonna be monitoring for potassium when it comes to either one of these. Make sure that if you're taking potassium wasting one, you're not going into hypokalemia. If you're giving a potassium sparing, you're not doing the opposite, and, having them go hyper. Well,
Are you okay? Drugs of choice for hypertension. Well, that's with your core. Are you good?
Yeah, I was just joking.
Okay, well, go quieter, please.
Okay.
I think that's very dependent on your core measures. I mean, typically, like you see, sometimes this kind of goes into like the heart failure ones too, but they kind of go hand in hand. But like a lot of times you'll see your lisinopril or your ACE inhibitors. I see those typically as like a first line one. What are the like big side effects of your ACE inhibitors?
So we talked about it.
We talked about it.
Mhm.
Monitor potassium, assess for angioedema, can cause a cough, but first rule out heart failure by assessing the lungs. Ooh, I forgot about that. Because I remember seeing like a question way back when it was like, oh, they're coughing. And I'm like, oh, we need to move, we need to do something. And they're like, assess the lungs first. And I was like, oh shoot. But so let's say that they're having this cough or they had angioedema on an ACE inhibitor. So then what is your next medication you're going to move to? Those are your ARB, so that's your sartan. So losartan is right here. And it's gonna have, I don't even really know the patho behind that, so sorry, patho Riz dude, but
Yeah.
it works pretty much the darn same, but doesn't cause the cough and should not cause angioedema. Yeah, you actually pretty much have it in order. Beta blockers, ARBs can be expensive, which is usually why you don't see it. So then you'll move into beta blockers. So you have metoprolol, atenolol, propranolol. I don't think I see propanol. I see metoprolol and atenolol a lot, and sometimes labetalol
Carvedilol.
and carvedilol. Your calcium channel blockers aren't as typically used for hypertension. They're more, what's the word, antidysrhythmic per se.
Like angina, yeah, it's dysrhythmia as well.
Um,
So for AFib, it could be.
so really you won't see like diltiazem used for blood pressure a lot of times, but if you do, you usually see it in combination with like 3 or 4 other meds. Those complements in African Americans, yeah. Then on to diuretic. I mean, yeah, you pretty much have it in order, but your diuretics are the only thing where I was like, those go higher on the list.
Yeah, they go higher.
But you can keep it like that, it's fine.
Oh my god, I think
Oh my god.
one I give them one.
That's what people want. This potato is really good. I don't know if I'm allowed to eat in here, but I'm gonna do it.
I'm eating in here. They can't tell me anything.
Oh, and she walked in and you had food up.
Oh, did I?
If you had that out, then yeah.
Okay. Would you put diuretics in between beta blockers and ACE inhibitors, or would you put it after beta blockers?
I put it there.
Yeah, because I think I see lisinopril plus furosemide combination all the time.
Yeah. I genuinely don't think you're going to need to know, like, you're not gonna get asked something like, what is the most common, like, blood pressure medication? Like, no.
We talk about nitroglycerin for your vasodilators. So does this affect blood pressure, heart rate, both, either, somehow? Well, what does it affect?
My sanity.
Hmm? Oop, that's not. Well, actually, no, it's not.
But okay.
Yeah.
Or limiting. Not inherently fully avoiding, but limiting your potassium. Loop diuretics educate potassium rich foods.
Correct. Are gonna affect your heart rate. Yeah. Iggy does mention that CCP is also one of the first line approach.
I don't
I
typically
don't see
see it. I see it used more in AFib or an antidysrhythmic. I don't see too many calcium channel blockers. I always forget the exact reasoning for it. There's some side effect or risk that comes along with it, but it's been a long time since I've had to really review that one. Um, where you don't really see it as often, but you'll see it more in AFib or as an antidysrhythmic.
I mean, I believe originally, your calcium channel blockers were made to be used for other stuff, right? Or were they the other way around?
Girl, you're going into the history. I don't know.
And then they realized that it can also affect angina, dysrhythmias. I see a lot of it more for dysrhythmias, like your AFib and stuff. I wouldn't be surprised. Yeah.
She pulled up the receipt, page 730.
Sheesh. What edition? What volume?
Why are you being chismoso?
I don't know. I don't even know if I have.
11.
They have an 11.
I have like the 9th and the 10th.
I don't even know if I have I don't even know which volume I have.
I don't open it. But yeah, that doesn't surprise me either. Like there's like how do I say? Like a pathway for which ones you take.
Yeah.
But I don't know the exact pathway, but I'm just going off of what I typically see, I suppose.
I see lisinopril prescribed more often than I don't think I see diuretics by themselves usually.
No.
It's usually lisinopril plus. Anyways, back to reality. Comes gravity. Is that the film?
I don't know. What you're referring
Like
to.
the knees weak, arms heavy, mom
Oh.
spaghetti. Alright, whatever. Okay, so let's talk about CAD. CAD is kind of like an umbrella term. It consists of two things. What are those? Very close, Theron. It does consist of angina.
Oh, she's asking for a repeat the question.
Oh, yeah, sure. Coronary arterial disease is basically like an umbrella term, where there's two things that make up CAD. Yeah, so very specifically, it's stable angina and acute coronary syndrome. We'll talk about from here. But first, I want to talk about these risk factors. What are the risk factors? It's very similar to the other risk factors. Yeah, pretty much. Just want to really hammer in how much these are all causing.
Hyperlip.
Yeah, obesity, hyperlipidemia, say CAD. CAD is what we're looking at here. Their lifestyle. What else? What's my favorite? What's my favorite thing? I always put one. I don't know if I've told you guys too much. Just like when in doubt, I put like a one that I always think
Oh,
of.
I've said it. Diabetes.
Yeah, diabetes for sure. Smoking, yeah. When in doubt, it's usually smoking because smoking causes everything.
A lot of stuff.
Uh,
Smoking and diabetes.
yeah, obesity. So you can see a lot of the same stuff here. A lot of anything that, yeah. So that's kind of like a good way to think about it. It's just all these risk factors for perfusion, and a lot of the time that's going to be correct on a lot of these. So things to think about here. Sometimes the age can matter, and maybe the. But that's my burrito. Why would you take my burrito?
I'm still hungry.
Okay, that's fine.
Genetic
Yeah.
predisposition.
Yeah.
Yeah.
Goes a little bit. So again, what is the education and prevention? Like, very similar to what we talked about. Almost word for word on pretty much. I'll just copy paste, but I just really want you guys to watch the same. Out of the same stuff. I really just want to hammer in how much.
Stop drinking. Well, I was gonna say with the drinking as well. So there's technically you can technically still drink. It's just the limit. So what's your limit per se? One for women, two for men.
Nice. How much is a drink?
I identify as a dude now. I can have another one.
How much is a drink? And like how do they define a drink? I forgot.
I don't think they ever really defined it here. Better don't drink. Yeah. I don't think they ever really defined it here, but at the other school that I was at, they defined it as, let me see if I remember correctly. I believe they defined it as one drink is like one shot, one beer, one shot.
Beer.
So like if you have a mixed drink, sometimes, like if you have yourself like a Adios or you have yourself like a Long Island, those those got a lot of alcohol in them, so that might count as two drinks. Just because sometimes they got like 4 or 5 shots in them. Oh wait, no, that would be like 4 or 5 drinks, my bad. Oh, that's what Professor Hadley. Oh, they actually did say it in lecture for you guys.
Oh,
Cool.
cool. Well, oh,
They put it up here. It's up here. The beers.
oh,
One
nice.
beer for women, two for men.
What about what about hard stuff?
I just said it to them.
Oh. Hold on.
I'll remember that.
So let's kind of again let's break down CAD. We talked about stable angina and acute coronary syndrome. So what does a stable angina kind of present as?
It's predictable.
Predictable.
Yeah, so it kind of has a precipitating factor.
Chest pain relieved by rest.
Yeah, it can be released by rest. I guess that kind of goes as a treatment.
Typically.
Yeah. Let's do about 15.
Relieved by nitro.
Yeah, also nitro. Mhm. So your rest can help with that by itself, but sometimes you need to take your nitro as well.
Same set of symptoms.
Mhm. Pretty much just been, yeah, pretty much. Not really much that kind of goes with it. Usually it's, and this is, if you want to be extra, this is associated with atherosclerotic plaque.
Womp womp.
So what do you guys know about nitroglycerin? Let's just kind of go over specifically. How's it given? What is your
Sublingual or spray?
yeah, we usually just learn here sublingual. And how much can you do? Yeah, so 3 doses, max about 3 to 5 minutes apart out each.
They want you to do 5 minutes. I think they teach us 5 minutes apart here.
Oh, do they?
I think so. Point. Okay, it was like
0.4.
0.0. I was like,
Interesting. I don't actually know this. Okay, so then 1 at 5. Okay.
Yeah, so then your duration is 15
Mhm.
minutes.
That makes sense.
Let's say that monitor blood pressure in particular. Ooh, that's good. I
like
like
that.
it.
And yeah, just kind of think about your when it comes to your nitroglycerin, it can cause some headaches from the orthostatic hypertension.
If systolic is below 90 to 100, hold. I think,
I think it's pretty good
yeah, I was gonna
baseline.
say, does this cause flushing?
Flushing.
It wouldn't surprise me if it could, simply because we're reopening everything up. But I'm not sure on that one, to be frankly
Not very
honest. It wouldn't surprise me if the answer to your question is it could.
Look it up.
Yes, I can.
Awesome.
No, actually, just because you asked, now I don't want to.
Wow. All right, I think we're doing extremely good on time. Is there anything that anyone wants answered that we didn't go over yet? Or I said that wrong. Anything that we did that anyone has questions on?
Blood flow.
Okay, Kaylin said that it can cause flushing because of the blood flow increase. Lori said NBTU hold at 120. Actually don't know. I mean,
Wait.
oh no, I was asking a question. This question that was asked here.
120 systolic? Is
I'm
that
guessing that's what's being asked, yeah. I'm not really,
that's
I think that's,
no.
no, I think that's too much, but
Because at that point, the blood pressure, I'm looking at that and I'm like, that's a very steady blood pressure. Once you get, and this is also dependent on policy, but typically you'll see 90. I see 90 a lot. Some places had 100.
my location's a
Yeah, PIH usually says they're ones that can cause lower blood pressure. They stop it at systolic blood pressure of 90. Um, so if it's like 90 or 100 or less, you would really be like, oh, maybe we shouldn't do this. Must be another BP drug I mixed it
I
with.
wonder which one you're thinking about. Might be one that like causes really, really strong vaso.
That would be my only guess. But the only one
Nitroprusside.
I was thinking nitroprusside. That was the only other one that I can think, but I don't know if it was gone over in 220.
No, I believe so. Or I mean, if it is, it didn't come up in anything I know.
Maybe the
Clonidine,
clonidine.
or maybe.
Ooh, clonidine. That's some strong stuff right there. Yeah, because clonidine, it's typically a patch as well.
Clonidine
And you leave it for like 72 hours. That wouldn't surprise me if that had a different parameter, but that one, I've really only done clonidine twice, to be honest. I don't know the exact parameter for that, but something to consider, maybe something to ask. I don't remember who did this lecture, but something to ask, I suppose.
Looks like Highfleet did it
Okay.
because they mentioned that in class.
Oh, right.
Start
duh.
filling with the drinks. Okay, so here we go. Acute coronary syndrome. So we talked about your CAD kind of being an umbrella term. Your acute coronary syndrome is also like another umbrella term. It's like an umbrella term under an umbrella term. So it consists of two things. Yeah.
Unstable angina and MI.
Your MI. Wonder what I meant.
I was about to ask you that.
I think this is basically, I think I just rewrote it here.
Okay. Hop off.
Wonder what I meant. Mhm. I think this is just like assessments of MI, but let's talk about so how does this present? Stable angina. What makes it different from your other angina talked about before?
Not relieved, by what? Unpredictable as well. Not relieved with rest and nitro.
Yep.
Nitro, no help. I love that.
Mhm. Yeah, so this one can
Only relieved with opioids. Ooh. Oh.
can
Okay.
occur at
Queen.
rest or with exertion, a real predicting factor.
Just because it doesn't have, I think this is something important to note. Just because it doesn't have or require like a precipitating factor, doesn't mean that like, say, like you could be doing an activity and be like, oh dang, that's crazy.
Yeah.
I have stable angina, and you sit down and you take your nitro, and it doesn't work, and then we figure out later,
Mhm.
oh, this is unstable. So it could occur with activity, or it could occur with rest. Could occur with either, but your stable can pretty much only occurs with some kind of stimulant or stressor. I think that was something I got hung up on in 220 when I was there. I was like, oh,
Hmm.
create mild limitations. What do you refer to as mild limitations per se?
Are you saying that because I wrote down for unstable angina can cause severe limitation?
Yeah, I don't know what you meant by that either.
Kind of just like, well, if you are just having this feel like this pain, I guess I didn't even remember what it is basically
It is a crushing term, actually, and I'm like,
chest pain and can occur at rest or exertion. So the reason why it has severe limitations is just because think about having pain, just you're just chilling and then all of a sudden it's chest pain, you're limiting.
yeah,
Yeah,
it
like
limits what
ADLs.
you can do. A lot of times, and this is a good thing to consider, like when you have a patient, they say, oh, I have chest pain. I'm not gonna be like, oh, okay, well, how was your breakfast like? And like move on from that. I'm gonna be like, well, I have to do my PQRXT now. So really consider, with your unstable and your stable, or any kind of time that someone says chest pain,
When did it start? What were you doing?
what were you doing? What does it feel like?
Mhm.
Because I believe, the intensity of your stable angina it's more severe, more intense than your stable. As well as sometimes the characteristic of the pain can change. So it's more crushing, stabbing. They might even feel cold in their
Mm.
chest because at this point, with unstable, well, then that kind of goes into my unstable can be an MI. Because I mean, well, okay, you're gonna go into MI next. I was like, I don't want to derail too far. So unstable can become MI.
Mhm.
So what exactly is an MI then? And why does it make sense that unstable can become an MI? Necrosis.
Yeah, so your angina is basically pain from ischemia to the heart, and I think I want to answer a question Khalid asked. It says, sorry, it says SMI, necrosis, and ACS is ischemia. So remember ACS, MI is included in ACS. So ACS involves unstable and MI. So, but yes, unstable angina is and stable angina is ischemia. And MI is typically associated with the necrosis, your heart.
Well, I mean, to an extent, but it's more with yours. Okay, anyway. There's another message.
Yeah. Yes, that's pretty much. I teach it here.
At this level, I think that's
Mhm.
really how they teach it. I don't think they, did you guys learn like the subdivision between STEMI and NSTEMI?
It is. So
Oh, they did?
that's actually what we're gonna talk about
Oh,
next.
okay, cool.
Kind of just the PQRC of chest pain. I think if obviously if the NTG is not effective,
Well, how do we know it's not
doesn't
effective?
take me
When should you call the ambulance?
after the 15 minutes.
That's
after
not
the
a
first-
question for
Oh,
you.
you sound like you were asking.
It's actually not after the 15 minutes.
Is it not?
No, so it's a good thing. Okay. So, let's say your patient was doing some activity. We're fighting in the corner and he's eating a burrito now. Let's say your patient was doing activity and they're like, "Oh, I got some chest pain. Okay, let me sit down really quick and let me take my nitro." And they take their first dose of nitro. And then at that point, if the 5 minutes pass and it doesn't work, yeah, after your first dose doesn't work, you need to call the ambulance. And you should also probably be telling them down some aspirin.
Mhm.
Because this is possibly a bigger issue. Mona. So yeah, so just know that for unstable angina, if your first dose is not effective of nitroglycerin, they need to be seeking medical assistance, medical care.
Oops.
Saw the piece of rice fall on you.
It-
Mona,
Go to the hospital.
go seek some. You need help. You need professional help.
All right. So now that finally assessment of MI. No, I think that's what it was. I think that it was like MI consists of 1 and 2.
Ah, I see.
So MI consists of what? There's two types of MI. What are they?
What they be?
Yeah, is you got your NSTEMI and your STEMI. So how do we determine one versus the other?
Oh.
So we have the EKG or not. So if there's no ST elevation, then you can't have a dip. So I guess I'll try to break it down.
STEMI is either it's along the isometric line, so there's no electrical activity, or it's slightly below.
Elevation. If you have normal ST or ST depression. Is what else will you see in both? So let's say you do an EKG and the patient has a normal ST fine. No, I see elevation or depression. What else do you have to check? When you guys are in the hospital and you guys had an MI patient, what is the thing your clinical instructor is always asking you about? So either way, you're gonna have to check your cardiac mark. And there's a few of them, but the main one we really go over is your troponin. There's two types of troponin. There's troponin 1, troponin T. Yeah, there's creatine kinase, there's CKMB, that's your myocardial one. BMP is more for heart failure, but it's not a bad thing to look at. Sometimes you can have your heart rate, sorry, your heart failure lead to an MI.
That is true.
What are the ranges for troponin? It depends on your hospital. I know Kalen's hospital has like,
Two different ones based off of your gender.
yeah, has different based on gender and also different units than some hospitals. So here they teach it as anything above anything like above 1 or 2.
Something
Sorry,
like
not that, sorry. Anything above like 0, I think they teach as being abnormal.
have that somewhere. I just realized what Alexis was trying to say with pizza. I was like, pizza? What the heck?
Is the neighbor talking about pizza?
No, CPK.
Oh,
California Pizza Kitchen. Yeah. We actually don't have. Honestly, same. After it was my coping mechanism.
mhm.
But I felt that one on a personal level.
Ooh, you curse.
I did not. I didn't finish the word. Actually, we don't have the range here. I think it was given back in first semester.
I came back in first semester and I just remember them saying
I think
anything
I just remember
anything above
like
or
one or
anything above
something.
0, sorry. Anything they said any troponin is abnormal if it's not
If it's not
above,
zero.
yeah.
It was something like that. But then it depends on the units that wherever you're at is using as well. So I believe, if I remember this correctly, that PIH uses nanograms per liter or nanograms per milliliter, something like that.
Mm.
Oh yeah, greater than 0.0.
Yeah, that sounds like, yeah, that
Right.
sounds right for like.
Lori, I trust you.
That sounds right for Lakewood,
You
but
sound
go
right.
over whatever your slides or your PowerPoints.
I think that's a trip back to 212. Oh, you just had a heart failure patient.
Nice.
Or
Or not nice, I guess.
yeah, I was gonna say, I was like, that was rude. You're just
Mhm.
saying like, oh yeah, the patient's in heart failure. Ha,
Mhm.
that's terrible. But yeah, I think it's whatever the value that they taught you here. For the troponin. So then you have two types, which is what Diego kind of said. You have the troponin 1, or I never really figured out what that is, in troponin T.
Mhm.
So, I mean, you already wrote it down, so I'm just gonna say, I was gonna say, which one do you check for an acute issue? And it's gonna be the one that he wrote. Your troponin T is gonna show you the troponin, kind of like how an A1C is like over the past 3
Yeah.
months. Your troponin will show,
Weeks, right?
troponin T will show over 2 weeks.
Yeah,
T
so that's why, yeah, T for 2 weeks.
T for 2. So yeah, so for troponin, how often are you drawing troponin on someone with an MI?
You guys actually answered this
Oh.
in your 220 chat.
I think so. I think that's why I asked it too.
Yeah.
Q8, Q6 sometimes,
Yeah.
and
I think I see 6 to 8.
6 to 8 usually.
Mhm.
Cool beans. When does it usually rise? Like if I have someone that came in, an hour and they're like, oh my gosh, like I don't feel good. Okay. So within 2 to 3 hours. So that's why sometimes you'll have your first one, and your first one, it'll be like normal or like maybe smidgely elevated. And then you redraw it in your 6 to 8 and it goes up further because that's just the beginning of it. Then you have your peak of it. So that's exactly why we're drawing them in a series. You don't ever really just go off of like troponin was positive times 1. Like that's a bit odd. You can, I've heard it, but usually they do series and you want to see, are we still going up? Ooh, that one I don't know.
I don't know. They don't really emphasize it. It's not a commonly pulled lab.
I think I mentioned it in my session. I've only seen it drawn at Beverly twice.
And she has gone to a full-on cardiac floor multiple times. So
But yeah, CKMB, I don't see Because I think I looked this up specifically, so it can indicate, it's like a technical cardiac enzyme, but it can indicate like other muscle damage. So it's not full-on cardiac specific. Troponin is purely cardiac. Oh, I heard something.
Mhm.
Um,
Yeah, any questions so far?
and
Yes.
you muted yourself.
Okay, so what are some priority problems when it comes to your MI and how do you respond?
Oh, goodness. Decrease pain.
So this person's having a heart attack. What are your priority actions?
Well, decrease pain is part of your priority.
Mm.
I'll take it. I'll take that as a priority.
Improve perfusion.
I love
And
it.
how can we do that? What can we do? Looking for two very specific things. So yeah, Mona is a good one.
Mona.
And just to keep in mind, it's typically done in this order. It's not actually done in Mona order. It's actually done in Owan.
I wouldn't put it there because they're not being taught that. I asked about that
Okay,
before.
I'll just go back to that. Yeah, you want an EKG? You want, yeah, the aspirin, which is part of Mona, and I believe that one goes from what's like the minimum dose to the maximum dose for that? I don't know.
Wait, what's your question? Aspirin?
Yeah, your typical
Well,
aspirin.
if someone's having a N-STEMI or a STEMI, I want to give them that 325. I agree with Lori.
There's the ring.
When do you go to the cath lab?
Yeah, so what's your part? Yeah, when do you go with cath lab? Within how much?
Ooh, Theorin put in a good point. Chewable aspirin.
Yeah. I think it's between 90 minutes, right?
90.
Mhm.
But typically, you know, for someone. Okay, I'll start it off like this. Which MI is worse? Is it your N-STEMI or is it STEMI? I have such a hard time trying to like say the difference. So why is your STEMI worse? Death. You know, you've got a pretty severe blockage. As opposed to your N-STEMI, it's maybe like a partial little blockage that's decreasing the myocardial perfusion and oxygenation. So with your ST elevated MI, at that point, we have a pretty severe blockage. And at that point, it can cause tissue necrosis and tissue death at the end of the day. So at that point, there's nothing more that we can do to better help this patient than get them to the cath lab within 90 minutes to try to put a stent in or, you know, use some kind of intervention, maybe some kind of fibrinolytic therapy through the coronary angiogram to try to break up this blockage or push the blockage against like the walls of the artery. Yeah, you don't really see it in STEMI. I don't think I've ever seen someone go to cath lab specifically just for STEMI or N-STEMI. Sorry,
might be placed on the heparin drip at that point.
I've seen some patients with N-STEMI placed on heparin drips, but that's very case dependent. It's more common for your STEMI, but that's another thing. So that kind of goes into your medication.
For STEMIs with the heparin drip, would you say it's kind of like when they're not able to, for some reason or another, not able to go into the cath lab in time. Not so sure if we have room for you, or we're not sure we're going to be ready for you. So heparin drip because we want to prevent the blockage from happening.
Pretty much. I was trying to find the right crown one and I couldn't
Yeah.
find it.
Yeah, in general, if you guys have questions on anything heart related, Kaylin's a really good resource. She has really specialized in heart stuff through clinical.
Stop.
Storm.
Stop. But yeah,
Yeah.
I
So
like what Maha said here.
Yeah.
NSTEMI is ischemia and venous STEMI is necrosis. It can lead to necrosis. So if you don't clear that blockage, you end up with that tissue death and necrosis. But if you fix it in time, we don't have as much or very, very minimal. So I like that point right
Yeah.
there.
And I believe, would you say it's accurate to say that someone that had a heart attack in the past, like a STEMI in the past, can then have that ST elevation from there on out on their EKG?
It's a possibility that they can have like a chronic slight ST elevation. Now, it's not going to be as severe as if they were having an active MI with ST elevation. It'll just be a slight elevation of the isometric line, but I can't recall exactly how far. But it won't be as elevated as someone who's having an active STEMI. But if they did have tissue necrosis and damage. Ooh, how fast does necrosis grow? I think we have that somewhere in our notes.
Dude, that's so extra.
Yeah, I was like, I don't think you're gonna have to know too much about that. That's a good question though. I remember it being somewhere. I looked through this while before I did the questions just to make sure because I was like, I expected that question,
Yeah.
and then I forgot.
Uh,
Oops. Let's see. We're gonna look through our notes really quick just to see what
Mhm.
we have. Because I feel like I saw it somewhere. You want to know what's funny?
What's up?
I was going through here, look, intra-arterial pressure monitor. We put the
baby.
line in. I just thought it was
Oh,
funny.
there's the phlegostic axis.
I just thought it was funny that we put that in.
So extra.
That's the extra. We went extra on our notes sometimes in 220.
What was the question again?
Oh, wait, go back up.
Yeah.
It's right here. The changes in myocardium after, oh, the chat box is in the way. After an MI. So explains need for interventions within 4 to 6 hours of onset. 6 hours after an, oh, this is just changes at the
Myocardium. Yeah, that's not really
Dang it.
important. I don't think we have the answer
I
to
don't
that
think we
one,
do.
but I also don't think you're gonna be.
Yeah, that was a question I wanted to know the answer to.
Okay. So yeah, things that they can do is the PCI, percutaneous coronary intervention, which I don't think you guys go over too much. I think it's more like a 232, but balloon angioplasty, the PTCA, which I guess is the balloon angioplasty, isn't it? The different.
PTCA.
Mm-hmm.
Percutaneous what? I don't know what that stands for.
Transluminal coronary angioplasty. But the
Oh.
type of PCI, I guess that is
It's a type of PCI. It's a subdivision because this one's saying that you'll usually hear like PCI with intervention.
Yeah, I
That's what
usually
they
think of
refer to.
PCI or balloon and cabbage.
Well, because you could have a PCI, but they didn't place a stent because there was no intervention.
Fair enough.
So you'll hear PCI with intervention and like it'll be like,
But
oh,
the
a
I
stent.
stand.
Okay, well, whatever. An angiogram, whatever you want to say. Oh my caca.
I
Okay,
put
where are we at?
meds here. I'm guessing that's because well, we talked about just know your Mona.
Your medications you didn't we talked about heparin, but it's not here.
It's not here because we didn't learn it in 220.
Did we not?
No. Did you guys learn about heparin drip? Not no, right? In 220?
Or heparin therapy for STEMI?
Probably Anthem, yeah.
Oh dang. Okay, yeah, I don't remember what we did in
Mhm.
220. Because at this point I was already getting patients with STEMI. I think that's why I was under the assumption. That's my bad. Okay. Mona.
What did I miss? Which one I'm missing? Oh, and just kind of what you. No. Okay. So what is a PTCA then? What are we doing? What are we doing when it comes to so this is what's going to happen in the cath lab. It's a type of PCI of intervention they do. What is it that they're doing? Yeah, so
Open the artery, dilate the vessels.
Okay, yeah. So what exactly is the end goal of it though? That's kind of what I want.
I mean,
That's kind of what it is. You know what I'm saying?
reviews.
Yeah.
I love it. I love to see it.
Mhm. So usually you'll see stent placements, usually the PTCA. So the stent is there to keep it open essentially. You can also do a few other things to try to just kind of get rid of the clot if there's a clot, or they have like it's like the thrombectomy and endarterectomy.
They don't learn about this.
You don't learn about those?
I
Really?
think that's third semester.
Do you guys know anything about endarterectomy and thrombectomy? And there's like a third one, I forgot. Thorectomy. No?
Yeah, I was like, they don't, that's third semester.
Or Sarah?
Sarah
Oh, yeah. Really?
briefly went over it.
So I think
Oh, it might have been in stroke in 212.
maybe, yeah.
Oh, geez. Feels like forever ago.
It was forever ago.
Now I feel old.
Okay, so again, just kind of understand what it is. You don't have to have you don't have to have a doctorate in PTCAs, but what we're doing as nurses is then your post-op care. So what are some of your post-op care that you guys are doing? That's what I want you guys to really focus on. Yeah. So wherever they did the PCI in, and then we're gonna assess perfusion. So how do we assess perfusion? Yeah, we got the pulses, basically your CMS, so your pulses, sensation, movement, ability. Um,
Assess for bleeding.
yeah, assess for bleeding is great. If it happens in the femoral, then we're keeping it straight.
Yeah, that's what
Yeah.
Alexis said. Don't strain, give Colace, keep the
Yeah.
leg straight.
That's straight. Make sure. I think it's Q15 for that. Q15
That
minutes.
sounds right.
Yeah, so that's
That's
seem like
general
it.
after procedure.
Yeah. So let's see.
When they have
Mhm. What else did you guys mention? Wide opening of the knees. So it kind of has to do with a lot of time it's PCI is done through the femoral.
yeah.
So we don't want the bent knees because then that can exacerbate the more bleeding hematoma.
Yeah, because when you bend the knees, you're gonna bend your hip. And that can cause us to bleed from the femoral site. Sorry, just to be clear, my patient came in with chest pain not relieved with nitro. Treat possible MI. I get vital signs, EKG, and start Mona. Also draw your troponin. Because you're gonna need that in combination with your EKG to be like, this is what's going on. But yeah, that's pretty legit. Yeah, on the way there, typically that aspirin 325 is usually not done in the hospital. It's usually done by if they're being transported by EMS, they usually do it there. If for some reason they didn't do it at home or they didn't do it, then we could do it. But usually it's already done for you, which is nice. But yeah, vital signs, EKG, draw your labs, start Mona. If your EKG comes back and you have ST elevation, you need to get them down to the cath lab.
If not, then that's when it's like, oh, it could be a NSTEMI. The NSTEMI could have it can have ST depression, or it could just be normal on the ST line, and then that's when you might consider like a heparin drip or just kind of monitoring them.
Well, you can do a heparin drip for STEMI.
Yeah, you can, but I'm just saying.
Okay.
Because the other one, the priority is kind of like the cath lab, and heparin drip is more like we can't get you to the cath lab in time.
Oh no.
Yeah, and then I kind of wrote here, done through the femoral artery. So the reason you're keeping your leg straight is to prevent bleeding and stuff, hematoma. You want the head of the bed not above 45 because that can put stress on the place on the area, and then also infection because think about where your femoral artery is. It's right next to your groin, and some patients can pee and poo, and that area can get infected. So CMS, bleeding, um, a lot of the main things here.
Stool stuff.
Mhm.
Yeah, that's what I was saying it.
So coagulant given to the stent.
Yeah.
Peyton,
I would
right?
say. Because think about it like this, they had a clot or they had a blockage and we also monitor urine output and administer IV fluids. We don't have that on our notes, but that is
That makes
correct.
sense.
You are correct. Yes. But yeah, for some reason that's not on our
It's
personal
not,
notes.
but yeah, so basically kidney function. Because perfusion, kidneys, they go together. So what do we do with kidney? And so it's urine output, one creatinine, IV fluid, because you want to perfuse the kidneys.
Oh yeah, so like if we put something invasive in, we put the stent in, I want to make sure because the body's gonna be like, oh dang, that's crazy. Let's try to clot it. So you have to make sure to keep that stent patent and make sure that your body doesn't react all crazy to it. Then you need to have them on VT prophylaxis. So your heparin, you don't see Coumadin in the hospital, but
Not really.
yeah, at that point, then we're looking at that.
And
Do we use aspirin as anticoag or we use heparin?
so aspirin's not even an anticoagulant, actually, it's an antiplatelet. So they have slightly different function. Your anticoagulants are going to be better for DVT and stuff like that. Your aspirin's going to be a bit more effective for arterial clots. So that's why uh,
I'm high key kind of sad.
why?
I went over that on the questions. I feel
Oh.
betrayed.
Call them out.
No, that wasn't my intention.
So heparin, Coumadin, Tegretol, is that the one it's called? Is that the one? I want to put out. It's like one that reminds me of.
Apixaban.
Yeah, Apixaban. That was close to Apixaban.
Yes, Apixaban.
And then Lovenox.
Oh, big words. Oh my god. Help. But yeah, that seems to be. Oh, and then wherever IV fluid. Did you put IV fluids
I
in
did.
there?
So
Oh, you
kind of
did.
the kidney function.
Okay,
you want
cool.
urine output, IV fluid.
Cool.
Use those
Because
kidneys.
as well that we are using contrast to do this. So I want to make sure I flush all of that out
Yeah.
because the contrast itself is very harsh on the kidneys. It's nephrotoxic.
What are some things we want to know if cause we're using contrast? So some things that are important to keep in mind. What do you guys think about?
If they're taking metformin,
Absolutely, yeah. Metformin. I think it's like how many days? Like 2 days that one of stop
48
taking.
hours.
And
Allergy to iodine?
yeah, so it's the allergies to I think usually iodine, shellfish.
Iodine. The reason that they're asking for shellfish is because it has iodine. Kidney problem. Patient have a pre-existing chronic kidney disease, or do they already have an acute kidney injury? Is there something wrong where they can't maybe flush all this contrast out and it gets stuck inside, or do we accidentally cause an injury to the kidneys with this?
And something extra for the future is you can give
We don't even know that right now.
you don't need to know that right now, but it's something that if you keep it if you hear it one time, maybe you'll remember it for 232. Because that's a thing that he likes to go over a lot. It's acetyl cysteine or whatever. So mucomist can be good for kidney protecting. You can also another extra thing you don't need to know is it can be good for acetaminophen overdose, Tylenol overdose. Your acetylcysteine is going to be your antidote, and it also helps the kidneys. But again, extra information that it comes up in 232, but Mr. Robbins likes mucomist a lot.
I say you were too
Oh, I was too quick. Sorry.
an internet connection bad.
Oh, my internet's bad. Okay. So what I said is mucomist can be used to protect the kidneys from like contrast and stuff. Your acetylcysteine is the generic name for it. And it can also be used for Tylenol overdose. But again, extra information, but if you hear it once, maybe you'll remember, be like, oh yeah, I remember that.
Cool beans.
And then last but not least, your cabbage. So what can you guys tell me about cabbage?
They're
So,
red,
so yeah, it's like round, green.
goes on tacos,
Yeah, I guess
fish
so.
tacos. Mm-mm.
I think you guys very
It's
lightly,
very
very
lightly.
lightly, but
I
it
think he
feels.
mentioned that it's a possibility that you could do a cabbage, but
Mhm.
I wrote that stuff in. That was me. So I don't know how deep that they really went into it for them.
Well, I'll just talk about it instead, just in case it comes up. That's the coronary arterial bypass program. Basically, what they do is they harvest an artery, usually from your leg, I believe.
Yeah, your leg or your internal
Yeah,
memory.
exactly.
Done if plaque blockage is way too bad. So if they go in there with your PCI, if they try to do your angiogram and they're
Mhm.
like, dang, it's like 95, 100% blocked. That's crazy. At that point, they're gonna be like, we're gonna have to do a cap. But yeah, so they usually take the internal mammary artery
Yeah,
because I actually looked up the path
the
on
lima
this.
one, right?
Lima, something like
Yeah.
that. Because it already has a slight connection into the heart. So it just makes it easier to bypass. But they can draw, they can take a vessel from anywhere. So that's your most common one. They can also take a vessel from your leg. And it's quite literally as it sounds, you bypass the messed up one. So you create a new road for the blood flow to go through.
Right. And so yeah, it's like kind of like she mentioned, an easy way to think about it is imagine like a freeway. It only has 2 lanes. It gets really congested. So the cabbage is basically like having an extra line.
On the fast lane.
Like having an extra line. So now there's an extra spot for the cars to go through, and it kind of helps with the flow, if that makes sense. So think about traffic. And another thing to think about with this one is this one assess the patient. So both low or high blood pressure can ruin the graft. If it's too high, it can just kill the graft. If it's too low, then it's not perfusing enough and it dies because it's not getting perfused enough. You also think for this one you want to go with also anticoagulant because you want to
Make sure
make
that
sure it doesn't get clotted up.
my road doesn't get congested again.
Yeah, so think of your cost like a little car crash.
Oh no, that's a big car crash.
Yeah.
It all lanes on the 5 north are done. They're gone.
Yeah.
Oh yeah, let's
Yeah.
see. They didn't go over too
Yeah,
much
I
more.
think that's pretty much everything.
I don't
here.
even think they talked about cardiac what's the word? Rehabilitation.
Not really particular.
Yeah.
Yeah. Any questions whatsoever?
I like the
Face,
happy
okay,
face.
okay.
You guys already went over hypertension. Wow.
Moved at the top. Yeah, focus a lot on your risk factors, I think. A lot.
Primary and secondary of that too.
Yeah, just remember there's a nice Kaplan question. Remember that unknown etiology, there's risk factors that can contribute to it. There's no exact cause. Another thing to keep in mind, I think, with secondary hypertension is maybe that you focus on fixing underlying problem a lot. Obviously, you're still going to take the blood pressure, but um,
It's existing because you have an
yeah.
underlying problem.
So, like for example, maybe the goal of someone with some sort of kidney impairment would be to work work on the helping out the kidneys so that they can stop taking their blood pressure meds because the reason they're taking the blood pressure meds is because their kidneys are messed up, for example.
I wouldn't say stop, I'd say reduce.
Reduce, yeah, or one of the things to think about. Any questions before I stop screen sharing and then just give you guys the PDF once I figure out how to, oh yeah.
Were you not sharing your screen?
I was.
Oh, weird. Oh, I don't know.
Anybody have a question? Are you guys scared?
What are we gonna do? Well, you guys still have Bella.
You will. I'll still be here actually. I plan on staying after I graduate. And although I think I'll be. You got what was you guys are gonna be third?
Mm.
I guess I think third semester is still the same curriculum, so I think I could stay and work on third and fourth, and then maybe they let me be a clinical assistant.
That'd be nice. They don't accept the
Oh,
slash.
yeah, there was some
Has to be like a
slash.
dash or something. So that's the hope, I guess. That's the dream.
That's the
The
dream.
dream. It's nice the tutor program is expanding so much, so we have a lot of new tutors that are coming in. Can you explain thrombocytes, please?
Thrombocytes.
From my
That's
thrombosis.
your platelets. A thrombocyte. A thrombocyte. Thrombo meaning um clotting site meaning cell. Your thrombocytes are your platelets.
What's the difference between California Pizza Kitchen and sorry, A and B? So
So CPK is kind of like your, I believe that one. Let me double check. I'm not just thinking of creatine kinase. Creatine kinase is like your generic metabolism waste, and your CKMB is a very specific cardiac. It's usually cardiac associated with cardiac. I think yeah, a lot of time we can diagnose. Yeah, CKMB is a form of creatine kinase, and I think creatine kinase can also be written CPK. So CPK is kind of like your generic metabolism waste from muscle breakdown or some sort of metabolism, while your CKMB is like specifically myocardial cells.
The CPK says creatine phosphokinase.
Okay, so CPK specifically is something.
Oh, wait, no, CPK2 is CPK and B, they're the same
Yeah.
things. CPK is just the broad term of it.
Yeah, so yeah, CPK is the same thing as creatine kinase. CKMB is a specific kind of creatine kinase. You go over hypertensive crisis priority. So your priorities with a hypertensive crisis, yeah, well, so remember, one of your rapid response, a hypertensive crisis is typically like a rapid response. You can do a rapid, whenever you're in doubt of something, you go and do a rapid response. And I think that's recommended as well for your parameters that we learned from 210. It was your pulse rapid. There's also some medications that you can take. So a lot people that are at risk for hypertensive crisis, they get like hydralazine, IV push, and stuff like that. In general, this person, we want to kind of make sure that they're not going to go into like any arrhythmias or just kind of like increase their cranial pressure.
Well, a big risk of your hypertensive crisis, you just stroke out. So my first priority is I need to get this hypertension back under control. So I need some pretty strong medications. I could use hydralazine, IV push, possibly. IV beta blocker, I
I
believe.
think metoprolol can be given IV, no?
I would say, was it labetalol you see more? Or propranolol, excuse me, propranolol. Propranolol IV. So most of your meds for that's gonna be like IV push, to try to lower that blood pressure down so they don't stroke out. I think that would be your number one priority, followed by your oxygenation, because if their blood pressure's that high, they
Yeah.
may not be oxygenating too well, so they might be struggling to breathe a little bit. If their oxygen's dipping out, put some oxygen on them.
A little bit of do what you can. Again, call a rapid if you need to.
Rapid.
More hands on deck is never bad. Much how that goes. And it says, do you think CNS and ANS will be on the quiz? CNS and ANS. What is that referring to?
Oh.
Central nervous system? Allergic nervous system? No, and I don't know. I don't know. What's it referring to? One has entered the week. And you guys got the PDF, right? Did I send it to everyone? Jocelyn, what did you mean by CNS and ENS?
Sure. Sorry. I don't know. It's like something, the peripheral or the central nerve. I don't remember. But it's like something Brooks teaches. for like farm?
Uh-huh. Do you mean like, are you talking about like sympathetic, are you talking about like sympathetic versus
Yes, that one, yeah.
parasympathetic? No, not
Yeah.
really. It's more important for farm. It helps to understand some stuff, but not a priority. I can give you something that can help with that, but again, it's not really a priority, but give me a second. But it's also extra information that right now is not the priority, but if you want it for later, I have the receptors kind of broken down, or at least I do for the sympathetic nervous.
I forgot to send you this. Could give it to.
Oh, okay.
I forgot.
How do I do
You
that?
could just talk about it
Sure.
at the end.
Give me a sec. Oh, here's something. Midterm review Sunday.
Yes,
Eh,
that's my.
That's for her, yeah.
session.
I'm doing oncology.
I'm also gonna plug Bella. I believe Bella said she's doing it from 12 to 2 on Saturday, but you can go and re-find her pronto message. She's doing weeks 4 and 5, the more recent stuff. And I'm doing the beginning stuff. And then I put a couple questions from like lower GI and whatnot in there. Yeah. Cool beans. So my session's going from, I'm gonna shoot for 10 to 12 because it's gonna be a packed day, with Diego doing a 12:30 to whatever time it ends for oncology after. Yeah, so my hope is that, I won't mess around as much. I'm sorry. I'll keep my talking to a minimum and I will try to get us through the questions as accurately and efficiently as possible. And then, yeah, and then we'll go into the other one if anyone wants to stay for oncology.
And that's why they be recorded. I think your sessions are not typically
I'm
recorded.
gonna try. I
Yeah,
forgot I
okay.
have the flash drives.
Oh yeah, I did give you.
I gotta find it again. Oh, I
Yeah.
kinda lost.
I'll end the recording so it processing.